Good morning. Also, Burger King. 7:52, November 13th, Friday. Into the KUAM News Zoom room we go, where Dr. Peter Lombard is standing by, and he's got a presentation. So, Doc, we'll just go ahead and give you the floor. I know you got a bunch of slides to run through. So, again, ladies and gentlemen, Link listeners, Link fam, he's our crunching COVID stats expert. Been with us since way back when the show was called Containing COVID. Dr. Peter Lombard. Doc, good morning.
Good morning. Thank you for having me again. It's been an interesting couple of weeks. Lots of things have happened. We've had an election, and we're seeing a big change in what's going on in the rest of the world for coronavirus. So we got CAR scores now, so lots to dive into. Feel free to just chime in whenever, ask me questions. I've got about 9 slides to get through here.
Right.
First one, just to start off, we got obviously you can see where Guam was about a month ago. We were in the top 5 in the U.S. for daily number of new cases per day. We kind of dropped down into the middle of the pack as our cases started to plateau over the last couple of weeks. But with the recent clusters, you can see we've shot back up to the top, I would say top 10. And that's mainly because you can see, look at all the other states. They're starting to really increase. It's a really dangerous situation out there for particularly for the Midwest. Our 75 on average cases per day per capita is it also qualifies us to be still in the top 10 in the world if you consider Guam to be a country compared to other countries as such. The death rate per capita, we're averaging about 1 death per 100,000 people, and that's actually qualifies us to be number 5 in the world and number 3 in the U.S. And that's because of our case volume and the number of deaths that we have. It doesn't seem like a lot, but when you take that per capita or you normalize it to the population, that's where we stand. And while that, it is bad for sure. I think that what we're seeing is we're just kind of, the rest of the world is going to follow us very shortly. The next month or two are going to look pretty grim for both the EU and U.S. states. Here you can see this just kind of validates what we're seeing in the U.S. in terms of cases. The hospitalizations are starting to rise. So I heard this morning up to, I think 30 states now have record numbers of hospitalizations, the highest numbers they've ever seen. We've been maxed out at our hospitalization for a while. Now other states are starting to see that as well. And when you consider, it's a lot more rural now where there's less resources to share. And I think that this is going to really affect morbidity amongst other folks that are being admitted to the hospitals as well. So Guam sort of falls at this. Right now we're at about 45 to 50 hospitalizations per 100,000. So we're sort of at this dark red mark here, but we've been there for a while. And as the weeks go on, you're going to see more and more states come up into that category as well. Based on deaths following hospitalizations, I think we're going to see in the U.S. over 2,000 deaths per day within the next couple months. And the vaccine just isn't going to roll out in time. So unless the states really make some big changes, they're going to, eventually they're going to start following the curves that we've been seeing here in Guam. Now, when you look at the age breakdown, I've shown this before, and this breakdown only gets to us through the 9th, but that was the first day that the cluster was reported. The biggest part of the cluster was reported from construction. And I've always been focusing down here on the yellow because that's the 60 to 69, and below that is the 70s and 80-year-olds. And that number, thankfully, even with the first reports of clusters, is staying low. You can see the biggest proportion of that cluster has been in the 40 to 49 age range. The numbers from the previous week over twice as many in that age range, and in the ones that bracket it in the 40s and 60s, those went up about 1.7 times. So we worry mostly about increasing deaths and hospitalizations, mostly from the older age ranges, of course. So that bodes well for what we might see from this cluster, at least over the next 2 weeks, for hospitalizations and deaths. However, where this might still bite us is if these clusters then affect people in the community and we see that transition from a younger age range into an older age range, within the next 2 weeks. So I've been trying to track our hospital census, and it seems to be we've been about 20 to 25% of cases, sometimes more, sometimes less, are end up being hospitalized. And of those, about 20 to 30% end up in the ICU. And I think that's fairly consistent with what I've heard some of the other guests that you've had on say as well. So, and that has been fairly stable. Initially, I know Dr. Uggen was concerned, especially in August. It seemed like we were admitting a lot more than we had previously. It seems to have tapered off a little bit, and it's been a fairly steady percentage of admissions of the number of positive cases that we've had. So I'm watching this pretty closely. This is a nice way for us to sort of see how bad things are, and to put into context what these clusters are going to do for us. You know, we talked about the delay between the peak in positive cases and then the peak in hospitalizations, and that sort of second wave in August that started, there was about a 2 to 3 week delay. We had a peak in cases again towards the end of October, and a peak in hospitalizations a couple weeks after that. Again, you can start to see here from the clusters, our average daily cases is going up again. That will probably peak within the next couple of days, and it remains to be seen if we're going to see a significant bump in hospitalizations there. I suspect it's actually not going to be that bad. But a lot depends on how quickly the construction companies were able to successfully give good instructions to their folks and their positive people, how quickly we're able to contact trace and test all the contacts of those positive cases. Now, what's interesting, you can see, to jump into the CAR score here, first of all, I do want to applaud Dr. Cabrera for all the time and effort. Obviously, I think the need or the effort or the desire to put out a single score, which is a little bit more understandable, is I think a laudable one. To have a single metric that's on an easy scale, it's not in fractions or decimals, it's not in the thousands, it's kind of like a very nice tight range of numbers that you can point to. Small fluctuations on a daily basis in the number of cases we have, it's not going to significantly affect the CAR score. And I think that was one of the biggest fears the governor had. It says, hey, so we have 5 cases in a day, and that's going to let people let their guard down. And as you can see, and he pointed this out too, the CAR score very closely follows the 7-day average of daily new cases, the 7-day average of test positivity, and this this effective retransmission value. Now, and you can kind of see that even if you go back to my graph with the 7-day cases, it really nicely follows that. So, on one hand, you could say, well, it's a little redundant. Then why don't we just follow, the 7-day average of daily new cases? And I think that's one thing you could certainly look at. You could say, hey, what if we just set our goal is 40 daily new cases on a 7-day average, and I think that would actually work out pretty well. Or you could say test positivity less than 7%, or effective RT less than 1. I think all of those 3 individual values would be useful. And I think for a lot of people, especially maybe the ones, you guys and people that follow the show, 1 number probably isn't even going to be enough for them, just because the CAR score is 20 on a given day. I think you're going to want more information anyway. So but some people, I think it will be nice. And as people get used to hearing the CAR score and understanding, what the goal number is, getting down to that 5 to 10 range is useful. I think it will be beneficial for us to incorporate that. Unfortunately, it is something unique to Guam. I don't know if other folks are looking at doing something similar in other places, but it's going to be hard to sort of generalize this to other locations unless, Dr. Cabrera or someone on his team also does some calculations for other states and whatnot.
A comparative, maybe.
Again, I think
Doc,
use it.
Sorry, Doc, I got to break in here real quick. We're KUAM FM in Agotnia, Guam. To our viewers on KUAM TV, Dr. Lombard's presentation will continue on the other side. We also have some great programming on the way with KUAM TV. But if you're into this presentation, and I think it's a good one, jump over to our Facebook live feed on our KUAM News Facebook. Or again, we're right here on the breeze, KUAM FM, Agotnia, Guam, 93.9 FM. My name is Chris.
I'm Sabrina.
Esta. Adios. And we're back. Doc, yeah, so that would be interesting because are you basically saying we're the only jurisdiction that's using a CAR score?
Yeah, Dr. Cabrera has made this all on his own. It's something that he's been refining since many months ago when he first introduced it, and I think through the iterations, it's gotten better and better. The times that I've had a chance to take a look at it and talk to him about it. So I'm saying it's useful. I don't. It's not the only piece of data. I think isolated by itself, it is still difficult to put into context what's happening. And for example, when you see a cluster, just because the car score doesn't tell you exactly what's going to happen over the next couple of weeks. But as a single value that's going to be sort of immune to daily fluctuations, large or small, it does give you sort of a picture of how risky things are if you were to walk out into the community today. So I think use it if you want to. Continue to use the other metrics if those things give you comfort as well too. But again, it took a lot of effort and time that he put into that, and I think there's certainly value to it. I did a calculation for using some research that I've been following that tries to calculate the number of true infections that we have out there in the community, and a lot of it's based on the test positivity. So down here on the red bars, those are our actual case numbers that we're testing positive. But if you do a calculation here in the background in the shaded light red, that's what we might estimate to be somewhere around what our true number of infections are in the community. So we're missing a lot of them, obviously, because I think we know that a lot of them are asymptomatic, and some people that have symptoms are just getting through it on their own. And using that number, we can also sort of calculate what's the cumulative number of people that have been infected. And I think I've commented before that this number, because unfortunately we've had so many cases, the positive side of that is that our cumulative prevalence has been going up and up. And this, of course, is going to be quite big error bars here, but this is showing we're probably close to around 25%, a number that I think I've referenced before. And at this rate, if we don't slow down, if we just can plateau, it would take only about 3 more months before we even got to that 50% mark. And the 50% mark, I don't want to use the herd immunity word too lightly, but the 50% mark is where a lot of people are start to say the herd immunity effect will start to kick in. We know, though, that there is a relative immunity effect that even less than 50%, we're decreasing the number of people that are susceptible, and the ones that are out and about more frequently, more of those people have already had the infection. So it's going to be harder to sustain outbreaks. And then you get a huge cluster in a very susceptible pool, like the construction worker, the prison workers. That's more susceptible people that no longer are capable of obtaining and transmitting the virus. We've been looking at this for a long time now, and it's, I think, pretty remarkable to see we've actually been fairly consistent over the last 2 months in terms of how much we're out in our cars. And that's, no policy change has really made a difference there. And I take some comfort in that, because if we just keep doing what we're doing, I think we're going to continue to see our numbers plateau. With the only caveat is we'll have to see if the cluster affects our hospitalizations and our elderly over the next couple weeks.
Hey, Dr. Lombard, this is Jason. I want to know, can you go back to your previous slide? I just had a question about one thing, because one thing that I find interesting is, you showed that, yeah, thank you. What is the reason for because it seems like the oscillation in that chart is very consistent. Is that for weekdays and weekends? How it peaks and then goes down and peaks and then goes down? It seems like that's very well defined.
Yeah, I'd have to go back and take a look at what day that peaks. And there's certainly a lot more traffic on what looks like one day out of the week. So I'm really not sure, Jason. But there probably is some correlation with the weekdays. And
yeah, because I know, like, just working in the news business, I'm just thinking, I know there are different signposts that we've covered, like the 31 airmen that we had that went around, and then now we've got the prison outbreak, and then we've got the construction outbreaks and everything. So I'm looking in terms of those, but I also think it's really interesting how the data would behave that way, why it would be so consistent up and down and up and down and up and down.
Yeah, that's a good question. I'll try to look into that. Maybe I can report back at the next time.
All right, no worries.
We've I've been tracking the predicted number of deaths based on the fatality rates for the different age groups, and the good news here is we're starting to see a few less deaths in actuality than what the cases predict, and I hope that trend continues. We're still on target for maybe close to 150 COVID deaths by the end of the year. But the light blue line is the regression of what the estimation shows, and the only why this could be linear is if our cases stay at the same level, and I do pretty firmly believe our numbers are going to start to plateau and go down despite this little bump of the cluster. I do think we're going to go down, and when the numbers go down, if cases go down, then both of these curves, both on the estimated and actual, of course, are going to start to trail off. If we can get anywhere down in the 100 to 120 range of deaths by the end of the year, I think that would be nice. So we'll have to watch closely and see what happens to the distribution of ages. I did see yesterday's numbers. I think we had 2 people in their 80s and like 4 or 5 people in their 70s. So that wasn't a good bump yesterday. Really great news that I heard from Dr. Babutsky about the antigen test. That is, we need more rapid tests like that. The only downside of those tests is that they're less sensitive, but if we only use it on people with symptoms, then we're going to be picking up the people that are going to be most likely to spread to other people. I was looking at a European country, I think Slovakia. They did something like 2 million antigen tests over the course of a weekend. This is like half their population. And if you look at their case curve, they significantly turn things around by doing that 2 successive weekends in a row. Massive testing, it works. You find people, and once you identify them as positive, you isolate them, and that's a really effective way to get things under control. It's we're not in a situation. No, I don't know if you saw in North Dakota, they just told their nurses that even if they're COVID positive, as long as if their symptoms are controlled, they're asking them to go to work because they don't have enough manpower, and same kind of problems that we've been seeing here.
Mm-hmm.
But I think we need to brace for a lot more trouble in the U.S. And if you got family out there, tell them just to stay safe and say, look to the future. This is the race to the vaccine, to getting that vaccine out. But we've got to hold on for 2 to 3 more months, and just keep doing what we're doing, and things will start to turn around. And that is my last slide. So is that pretty straightforward?
Yeah, Doc, pretty straightforward. So what do you think, mathematically possible for us to get rewarded with Christmas if we do the things we need to do between now and December?
Well, I don't know if you should necessarily put it like that, Christmas or no Christmas. And of course we're going to have Christmas, and we'll celebrate it as well as we can with our families, even if that just means it's with smaller groups of people than normal.
You know what I mean,
still
Doc?
Certainly be there.
Yeah.
What was that?
It's kind of indicative with our market that, like, when we go through these waves and these phases and everything like that, because of because of the way our healthcare system responds, and the limited number of resources that we have, that our phases tend to be like a little bit longer than other like comparable markets in the States. Because I know you said the behavior was kind of
I think
similar.
every location is unique.
Mm.
What was that?
No, I said you said the behavior is kind of like to some degree we parallel like what some other markets in the States are going on, but I was like, is the fact that we're out here and we're like small community. You said there are benefits to that, but also because we've got a rather brittle public hospital, and like it's becoming overwhelmed. Yeah. Is when we go through these phases, are they a little bit longer relative to like what? Because we saw what Italy went through, we saw what New York City went through, and everything like that. And it seems like ours are like a little bit more prolonged.
Yeah, I think it's really tough to make clear comparisons between different locations. There's so many circumstances that will make one location unique compared to others. We were looking very much like Hawaii continues to look over the summertime, and partly because I think we had some things going in our favor. We talked about our isolation, our border control. We talked about people maybe being a little bit more compliant because we were more concerned about our families. But then everything blew up, and I think it was because of our Achilles heel of our insufficient testing and contact tracing, and insufficient manpower to be able to do all those things. We maybe need hundreds of contact tracers to do it effectively, like we see in other Asian countries. Now, whether that's possible or not for Guam, that's for other people to decide, I guess, and put resources towards. But that's always been our Achilles heel, and it blew up. And I think Hawaii's been extraordinarily lucky, and they're of all the states right now, them and I think Vermont or New Hampshire, like they're the driest timber, and with all these cases in the U.S., there's going to be people traveling to Hawaii for sure over the winter, and they're at significant risk of having a massive outbreak over there. So, watch them very closely. If they can continue to do a good job with border control and stomp out their clusters quickly, I think there's a chance that they're going to be able to keep their numbers where they are until the vaccine comes out, and they'll be looking like the true winners of the pandemic. Mm-hmm. So it is what it is for us. We know, I think we always knew. Even I remember Dr. Akimoto from one of the first days was saying, he felt like that was our weak link. And I think that it was very prescient, because it turned out to be, we were just hoping that we'd be able to get through and staying at the same level, but it just didn't turn out that way for us, unfortunately.
Mm-hmm. Yeah, I thought from that one chart that you had, Doc, with the one that was expressed everything like in the lower 48, and but Alaska was kind of like, at least to me, was like surprisingly high in terms of like, what was it, the number of deaths per 100,000, or the number of positive rates. Like I would just naively think that because of where Alaska is and just the sheer landmass relative to population, mm-hmm. and everything like that would make it like a little bit smaller. And I was actually surprised, like you just said, that Hawaii is doing so well now, because we just talked to them, when we did interviews, and they said, really, really dicey here, and that was maybe like 3-4 weeks ago.
Yeah, well, I guess when it comes to, I'm saying they're doing well in terms of their cumulative prevalence. I mean, like I said, we're close to 25%. Hawaii is probably at like less than 5% right now. I mean, when you take of all their population, how many people have been infected to this point? I mean, and when you look at their daily numbers, I mean, they they've had some days in the hundreds for sure. I think even recently. But that's for a population that's many times the population of Guam, and compared to other U.S. states, they're still doing much better, and they're not yet seeing the type of exponential rise that other states are seeing. So, but we got to watch them closely. They do look like they're trending upwards a little bit over the last couple of weeks. So we'll have to watch them pretty closely.
Yeah. Well, you had me at linear regression, Doc.
It doesn't get out much. Doc, anything in closing here? Very concerning numbers. Obviously, I remember back when we tried to get you on, and you'd be like, "Oh, we had 2 cases in the week, so what's the point?" Right? During that lull where we had 0, 0, 1, 1, the daily test reporting. How concerned are you with these numbers that just continue to come? The hospitalizations, the deaths, the positives, the clusters.
Yeah, I think if we get through this cluster, and watching the charts closely over the next week or two, if we get through this cluster without a significant rise in our hospitalizations in the next 2 weeks, and I'm going to feel really good about where we are, to be quite honest. And I think our numbers are going to continue to decrease slowly when it comes to our daily average of new cases, our CAR score. All of these things should continue to go down as long as people keep doing what they're doing. And according to our mobility graphs, we've been fairly consistent in what we've been doing. So, and I honestly think a large part of why I'm a little bit more optimistic is because our prevalence is at 25%. We have less numbers of susceptible people out there. So I'm a little bit more upbeat. It's unfortunate that what it took to get here is close to 100 deaths. But it is where we are right now, and I think that I don't see a huge risk of our curve all of a sudden shooting up again in an exponential fashion. I just don't see that happening if people keep doing what they're doing.
All right, Dr. Peter Lombard. I think one of the takeaways here was you are saying we could see 150 deaths by the end of the year, right?
Yeah, I think that's what we've been tracking at if the numbers stay the same. If our daily cases remains in that 80 to 100 range, that is fairly realistic for the number of deaths. So, if we want to bend that curve down and decrease that number of COVID deaths that we see by the end of the year, we need to do a better job of what we're doing. And that it's just, to some degree, yes, we all have a personal responsibility, but there's many other things that play a role here, including how many tests we can do, how we can contact trace, which is, equally, if not more important, and potentially could have a bigger impact on the number of cases and deaths that we see throughout the remainder of the year. And if we're lucky enough to start being able to vaccinate sometime in December, that's going to help us as well.
Thank you, Doc.
Welcome.
Be
Thanks
safe. It's Friday. Grab some virtual empanada. Live it up a little, man.
Are there virtual calories in that too?
No, yeah, it's all virtual, man. Low to no calories. There's air fried. There's an air fried option. Thanks, Doc.
Thanks.
Okay.